All right, it's time for our Module 3 pre-class lecture. And this time we're talking about religion and spirituality as it relates to transcultural nursing. So as always, grab a pen and paper and please study along with me and actively take notes as we go through this material. In terms of religion and spirituality and transcultural nursing, we really want to focus on practicing wellness, holistic wellness for our patients. And that includes intellectual and social, physical, spiritual, occupational, emotional, and environmental wellness. And so well-being includes all of these different facets of health, and spirituality is one component of that, which is why we discuss it in this course. So we must care for both the body, the mind, and the spirit of an individual to realize optimal patient outcomes. It's not enough to just look at that monitor and look at the blood pressure or the vital signs. We really have to take into account the whole patient, body, mind, and spirit. Evidence actually shows that spiritual health is linked with physical and mental health. And so it's not just a nice thing to do, it's actually evidence-based science to address the whole person. So we want to talk a little bit about religion versus spirituality. Religion represents an organized system of beliefs about the cause, nature, and purpose of the universe. Often, it includes the belief or worship of a supreme being or higher power. Religions may have organizational structures, leaders, sanctioned meeting spaces, and written doctrine. And religion often aims to explain the value of human existence and the meaning of life, and is guided often by a moral code. Spirituality, on the other hand, represents an individual's personal experience or effort to find meaning and purpose in their life, and often connotes an experience of connection to something larger than themselves. Spirituality focuses on individual growth and is more subjective and individualized, emotionally based, and focuses upon an inner understanding rather than an external or community expression of devotion to worship. Now, not all of our patients may be religious, but all of our patients have some kind of spirituality. We're going to unpack that idea more when we meet together in class. So, to reiterate, a person may be both religious and spiritual, or they may be spiritual but not religious. In fact, it's estimated that nearly 1 in 5 Americans in the US define themselves as spiritual and not religious as of 2013. Especially, this is often more common in the younger generations. So when we are practicing care for our patients and we're thinking about holistic care, including body, mind, and spirit, we need to do a spiritual assessment for our patients. So part of the spiritual assessment is going to include the assessment of religious or spiritual preferences, religious or spiritual satisfaction, needs, issues, or concerns. And it's not surprising when patients who are very ill, some come in with some sort of spiritual distress and request or require a spiritual intervention. Spiritual distress is defined as a disruption in the life principle that pervades a person's entire being and that integrates and transcends the person's biologic and psychosocial nature. In other words, a patient who comes in critically ill or a patient's family member who comes in with a critically ill family member may not consider themselves very religious, but then all of a sudden they may be requesting like a spiritual counselor or chaplain to meet with them at the bedside. It's often in those, worst moments of your life, those trials in your life, that you kind of think about the bigger picture and want some support for that. Now, spiritual interventions can be nursing interventions, or sometimes it's just about getting an intervention of a referral to the spiritual department of the hospital or the clinic where you're working. So make appropriate referrals to spiritual services or pastoral care. Utilize in-house chaplains as available. Sometimes hospitals have chaplains actually on call and are available 24/7 in the hospital, and other smaller hospitals do not. And at some points, hospital resources or for an outpatient clinic, for example, may not have a pastoral or chaplain service available. In that case, your institution should have a list of local chaplains or pastoral care people from different faith backgrounds who can come in to support that patient. Or you might ask the patient if they have someone that they want to come in from their own congregation or their own religious belief to come support them. And remember, HIPAA still qualifies here. A chaplain and an external religious institution is not covered under HIPAA. So you would not be able to contact an external resource without the patient's express permission. Now, spiritual distress is something that we can see with patients who come in, especially if they're having some kind of life crisis or significant illness. Spiritual distress is a patient who expresses lack of hope, meaning or purpose in life, and the inability to forgive themselves. They may express being abandoned or having anger toward God or their higher power. They may refuse interactions with friends, family, or clergy or chaplain. They may request actually to see a religious leader. They may be in so much distress that they want that support. So we want to pay attention for any sudden changes in spiritual practices or the sudden lack of interest in nature, in spiritual literature, or sacred objects, especially if this is a change from their normal. Now, prayer and sacred items are practices and items that may be valuable to your patients. Prayer is a spiritual or religious practice that allows a human connection to a divine spiritual or natural entity. Some people even use the word meditation or contemplation interchangeably with prayer. Prayer is a practice that may need to be supported with adapted spaces, uninterrupted time, or other practices. Certain patients, because of their religious beliefs, may need to practice at certain times of the day or facing a certain way and are not to be interrupted during those spaces. So as we ask the patients what's important to them during their care and during their stay, if they're in the hospital, we want to facilitate as much as we can. And sometimes just signs on the door, please do not enter, come see the nurse, can help facilitate that uninterrupted time. Sacred items or symbols like jewelry, medals, icons, totems should be accessible to the patient. We want to make the patient's space their own, and those types of meaningful sacred items are important. In class, we're going to talk about whether nurses should pray with patients and family, and I'll be really interested to hear your opinions on that. It's really important to respect patient beliefs and integrate their requests into their care. Remember, our patients' requests are not an interruption to our work. They are the purpose of our work. And sometimes we can get so bogged down with the task list that we're doing that we forget the human, the real personhood of the patient in the bed. So we want to support them with these spiritual requests as much as possible. And remember that we're not to impose our own spiritual or religious beliefs or pray with or for a patient without their expressed permission. Patient-centered care means aligning with the patient's values and wishes and preferences, not with our own. So when we're planning spiritual nursing care for a patient, want to ask the patient what kind of support they would require or request during their stay to support their religious or spiritual needs. This may mean about rituals, scheduling, items that need to be in the classroom, a person from their faith background to come and support them, etc. And for some patients, it may mean declining some of the medical treatments. For example, Jehovah's Witnesses typically decline any kind of blood transfusion because it is against their religious belief. And if that's the case, we just really want to support our patients in the decisions they're making. And then offer them alternatives when available. Now, there are a number of spiritual and religious beliefs that can actually influence healthcare practices. So the nature of illness may be integrated to beliefs as illness being a spiritual imbalance, spiritual disease, or a result of sin. In other words, sometimes people interpret causality in their life to be, oh, you must have done something wrong, or this is a consequence for your actions, and so on. This could also include ascribing illness or disease to an innate presence of sin or evil in the world, or as a punishment for individual sins of the past. In other words, it might just be, well, the fall of man in general has caused sin to enter the world, and therefore bad things happen to good people, kind of thing. The experience of healing may be ascribed to spirituality and not related to current treatment practices. So you may have a patient that says, God healed me. I can't explain it. It doesn't make sense, but God healed me. And in your head, with your medical background, you may be thinking, yes, I can understand where you're coming from. And also, we gave you this medicine. It made you feel better, right? But we really want to support the patient's interpretation and meaning behind their illness journey and as they're going through that. We want to consider modesty. Patients in different religions may have laws or traditions that are related to dress, exposure, or whether they can work with a male or female healthcare provider. We want to support those needs and ask the patients what's best for them. And specific religions may have diet restrictions. For example, strict Jewish patients will not eat pork or shellfish. And so we want to make sure that we have those dietary modifications in their chart. Other things we can do to provide spiritual care is practicing presence. When we're in a room with a patient, it's really easy to avoid eye contact and just get on with your day and type in the computer, make the bed and all the things. But if you just sit down with a patient and you just literally practice presence in the room, can be very open and supportive to the patient. We can converse with the patient about their spirituality, about their religious practices, and if they have preferences for prayer or meditation. We can allow accommodations to support religious practices and prayer. If, for example, you have a patient who's Muslim and they need to pray at a specific time of day, and that means not going to X-ray right now, work with the X-ray tech to make them come back in an hour and so that you can support their prayer needs. And then ask the patient what their needs are and ask the patient if their spiritual needs are being met or if there's anything else we can help with. Remember, there is no one size fits all with patients. So even if patients identify as being from a specific faith background, we still want to ask them what that means for them. In terms of nursing management, nurses are considered generalists in terms of spiritual care. So when patients are in the middle of a crisis, we have therapeutic communication skills that can help us navigate a patient through that. But really, there are experts in the healthcare world who are meant to deal with these kinds of situations, chaplains and clergy and other spiritual mentors. So just like we're not experts in physical therapy or speech therapy or occupational therapy, we use experts in the healthcare to support the patient's needs. We need to do the same for spiritual care. Spirituality cannot be handled like a physical condition or diagnosis. Be mindful that you do not care in a paternalistic manner. Paternalism means doing something for someone else or making decisions on behalf of someone else with good intention behind it for that patient's own good. But we really want to make sure that we're not doing that and that we are allowing the patients to be the drivers of their healthcare. Primary spiritual caregivers are often friends and family, and so we don't want to minimize the value and impact of having visitors at the bedside and the spiritual support they can provide. And as I mentioned already, with all cultural facets, never assume knowledge of a patient's beliefs. Always ask the patient how they practice their religion and what their spiritual or religious preferences are. Grief can often be a time where we really see spirituality expressed and sensed by patients and their family members. Serious or terminal illness, death, or dying often are associated with religious practices and rituals. Religious and spiritual beliefs may involve taboos, specific death practices, methods of preparing a body, specific funeral practices, and different means of bereavement, grief, and mourning. Religious and spiritual practices may alter with an unexpected and violent death or death of the child. A traumatic, too soon kind of death can accentuate spiritual distress in a family member. There exists a large area of study about grief and grief responses, and these phenomena occur in all humans, but can be influenced by cultural, spiritual, and religious beliefs. So we want to really understand the family and the patient's preferences in terms of grieving. Who needs to be at the bedside during the grieving process? Do they need to have any spiritual practices done at the end of life? And what do they feel about preparation of the body, autopsy, organ donation, cremation, prolonging life, all of those things. Different kinds of grief. Abbreviated grief is genuinely felt grief that is only experienced for a brief time. Anticipatory grief is that genuinely felt grief experienced before the event actually occurs. I saw this in my aunt when my grandfather was dying. She knew he wasn't going to last long, and she was kind of grieving before he even passed. Disenfranchised grief is when the person is unable to acknowledge the loss of others, so they just kind of disassociate from it. And complicated grief is unhealthy, maladaptive grieving, which is defined as grieving for greater than 6 months that causes impairment of functioning normally. Spiritual and cultural factors that influence the loss and grief response of an individual. Spiritual and religious beliefs have influence on how people grieve and influence loss. Oftentimes in many cultures, people who are male are expected to be strong, and you may see males expressing less emotion during grief. It doesn't mean they're grieving any less. And socioeconomic status impacts availability and access to support systems and additional resources. I'm not sure exactly how much funerals cost these days, but it is extremely expensive. And so that can really influence how a family goes through this if life insurance is not available. So there are ways to support a patient and the family members through the grieving process when a patient is dying. Oftentimes, patients and their families avoid the topic of death as there's fear and avoidance to the topic. But there are ways that we can help our patients die with dignity. Helping the client to identify personal feelings about death, focusing on the patient's needs, determining what the patient knows about their illness, being honest and direct with them when they ask questions. We're not going to lie about how bad things are or how things are going. Make time to be available. Again, that practicing presence, being truly with the patient, emotionally, mentally, not just physically. And establishing that communication relationship, therapeutic communication. Cultural beliefs related to suicide or assisted suicide will vary. The idea of medical assisted death is growing in popularity in many countries, and it's growing in popularity in America, where patients who have less than 6 months to live and have extreme pain and disability are given the option to have medically assisted suicide to hasten the end of their life to avoid suffering, kind of like we see with pets in our country, that we often practice euthanasia to avoid unnecessary suffering for our pets. Hospice care is another service that we can see at the end of life. Hospice care is effective at helping provide support to a patient with 6 months or less to live, as well as to their family. And the goal of hospice care really changes from trying to fix everything, curative, to comfort care, where the goal is no longer to prolong life, but to allow the patient to be as comfortable as possible. So when we have a patient or family who is going through an end-of-life experience, family support is an important part of the plan of care. We want to use therapeutic communication and use empathy and caring presence, explain what is happening and what to expect, be calm and have a patient demeanor. Be comfortable showing emotions in front of the family. It's okay. We are human as well. And if they cry, you can too. We need to be human as we practice nursing as well. And we want to encourage loved ones to participate in physical care as they're able. So it may be including allowing them to assist with bathing, talking with the patient, reading to the patient, holding the patient's hand, and in many situations, even allowing family presence during a code. Research shows that families who actually witnessed their loved one being coded, having CPR, felt like the providers did more for the patient than those who were not present during the code. Other considerations during the death and dying process related to religion and spirituality. Organ donation may be prohibited by certain religious traditions like Muslims and Jehovah's Witnesses. Preparation of the body, funeral arrangements, and potential cremation Cremation may be prohibited or encouraged depending on the cultural or religious preferences of the patient and family, specifically Hindu, Muslim, Jewish, and Catholic traditions. Timing of the funeral and decisions to transfer the body may be time sensitive. Muslims and Orthodox Jewish traditions require burial of the body within 24 hours. And postmortem care varies with religion and culture, so check with the family to see how you can accommodate for them to perform any death rituals for the patient, like bathing the body or having clergy present. That's going to wrap it up for our pre-class lecture on religious and cultural beliefs and about the death and dying process. We will unpack this further in class together. Thanks again for watching, and I'll see you next time.